The recording has to be
Okay.
restarted then.
It is started soon.
Recording started?
Yeah.
Yes, sir,
Yeah.
recording started.
Should I share the slides?
Yeah.
Yes, sir, please.
So, very warm good evening once again. This is 146th welcome to Thursday Musings. We have a very knowledgeable panel, all very good friends. Today we'll be what you say directly from the horse's mouth, because the person who is presenting, she has much research in this area, and it will be a great evening today. I'm handing over the session to Professor Tufan Patti sir. Sir, over to you. Sir is the chairman of this program. Sir,
Thank
please
you,
take
Dr.
over.
Alim. So we are into this important session, 146th edition of Thursday Musings, and welcome everyone. And I have to briefly introduce the moderators because they are very much well known. Dr. Amrit Patudosi and Dr. Alim Siddiqui, vibrant young leaders of Indian Psychiatric Society. Dr. Amrit Patudosi is President of Eastern Zonal Branch. Alim Siddiqui is Treasurer of IPS. Our chairpersons, Dr. Hitesh Khurana, MD from BHU and postdoctoral fellowship from KGMU, is professor in charge of geriatric mental health care, affiliation with Institute of Mental Health, Pandit B.D. Sharma, UHS, Rohtak. Welcome, sir. Dr. Aninda Sidana Gupta, daughter of my dear friend Dr. Rup Sidana, first introduction, and consultant psychiatrist, Chandigarh Hospital, Hanumangarh, Rajasthan, education qualification, MBBS and MD Psychiatry, fellowship in psychosexual medicine, ex-senior resident of EVAS, 3 years of experience, ex-assistant professor of Santosh Medical College, Ghaziabad, ex-consultant psychiatrist at Techchan Sidana Memorial Hospital, experience of running Prerana De-Addiction and Rehab Center, ongoing certificate course from Beck's Institute and CBT. She has received the Women's of Substance Award in 2022 at Jaipur for working in area of mental health and areas of interest, marital therapy, psychosexual problem, and de-addiction. Welcome, Dr. Aninda, and welcome, Dr. Khurana. This proceedings of this meeting onwards is handed over to you as chairpersons. Please conduct, carry on. Shaman has to introduce the speaker, Dr. Meena Chandra, and Shaman has to introduce the topic.
Aninda, if you can speak.
Introduce the speaker.
Okay, I will introduce ma'am.
Yeah.
Good evening. We have a very intelligent and the reputed speaker today, Professor Meena Chandra. She is head of Department of Psychiatry and Center of Excellence in Mental Health, Atal Bihari Vajpayee Institute of Medical Sciences, and Dr. Ram Manohar Lohia Hospital, New Delhi. She is MBBS gold medalist and has received gold medal in DNB Psychiatry, Dr. Sardar Menon Gold Medal, and has done her fellowship in drug and alcohol medicine from Australia and is PhD Neurology MN-AMS. Commissioner of Police Delhi Award for providing COVID-19 related mental health care support to Delhi police personnel. She has 18 years of experience as PG teaching and has numerous awards and honors to her credit. 46 papers in national and international peer-reviewed journals, 5 book chapters, and 1 national standard treatment guidelines. Her areas of interest include cognition, dementia, environmental determinants of cognitive impairment, including air pollution, mobile-based health intervention, psychiatric morbidity in diabetes, burnout and mindfulness, autism and disability. And she is also the member of Human Rights Committee of IPS this year and is working very well in that. Thank you, ma'am. I will request Dr. Hitesh Khurana sir to please introduce the topic and then we can hand over to ma'am.
Thank you, Dr. Sidana. When we talk of Sikkim, when we talk about dementia, I think our talk almost every time is full of pessimism. And when we're talking of the treatment, many people consider it as a neurodevelopmental disorder. Many kind, so we are so pessimistic that we even call it the neurodegenerative disorder. And when we talk of treatment, I think till now we are finding for whether we have any kind of gold standard of treatment of dementia as far as the psychopharmacology is concerned. And this battle is not with the dementia, this battle is not something very new. We have been dealing with it since the time historic. We all know that how the Alzheimer's has discovered, and since that time we are having this battle going on against the dementia. But when we come to the 1990s, we were still very pessimistic and we were still very hopeless about what we can do for treating the dementia. At that time, we don't have and had any other medicine, but we were thinking of only tech. Whenever dementia patient is there, we are thinking of tackling and nothing else. At that time, there's three different scientists which include the Spector, Orell, and Woods at the different universities. Spector and Orell were at the University of California, and Woods were at the University of Bergen. They thought together whether everybody is thinking about the psychopharmacology, and let's think about the non-pharmacological methods also. And they sat together and devised a hierarchy of different kinds of very simple and very entertaining activities, which were leading to the chain of full of complexity to the extent of problem solving skills in this particular chain also at the end. And they thought of trying it. And in 1996, they published an editorial that was named Tackling and versus non-pharmacological therapies, whether there is any kind of competition. This of question mark. And ultimately after that, they ultimately in that article wrote that for non-pharmacological methods also have a potential that these can be used in the treatment of dementia and the other related disorders. And from that, we started becoming a bit optimistic about the treatment of dementia. And ultimately in 1998, they published a full protocol. And in 2006, the researches which were conducted on this particular protocol, which they named as the cognitive stimulation therapy, the findings were so convincing that ultimately the National Institute of Health and Clinical Excellence, they thought if not any other therapy, dementia people must receive this treatment, which appears to be gold standard. Why gold standard? They could notice that at least there are three different kinds of evidence which are attached to the cognitive stimulation therapy. That is, first evidence, the clinician himself is able to know that the patient is improving on the different kinds of psychological tasks. And second, the subjective improvement of the patient and the family member. The patient's family members used to say, no, our patient is able to remember. Now the patient is, the language has improved. And so objective as well as a subjective well-being was there with the cognitive stimulation therapy. And when it was seen at a in national level, it was seen that the financial burden also decreased. Financial burden also decreased when we included the cognitive stimulation therapy in the treatment of dementia, and ultimately it became a gold standard. And till now, I think this is the only treatment which has been included in the guidelines for the treatment of non-pharmacological treatment, which has been included in the treatment of dementia. Most of the research has come to us from West, and from India. We know that there are 2 or 3 centers only where the research is being carried out. And Professor Meena Chandra is one of them, who is known for putting not just the hard work in her research, but also putting her heart also in her research. And so, not taking much time, I directly hand over to Dr. Meena Chandra to tell us that what is going on at the international level, what this cognitive stimulation therapy is, and what is the Indian scenario. Over to Madam Meena.
Madam,
ma'am,
you are in mute. Mute. Madam, you are in mute.
At the outset, I would like to thank Dr. Aleem Siddiqui, who came up with this topic. He asked me for a number of topics which I would like to speak on. This subject is very close to my heart. Dr. Tufan Pati and Dr. Amrit for giving me the opportunity. Aninda, dear, for a very kind introduction, and for also to Dr. Hitesh to set the right perspective about my talk today. So without much ado, I will start with my presentation. So when we think of dementia, we think of really pessimistic kind of, we have this whole pessimistic kind of picture, as if everything is downhill right from the beginning. Can everybody see my slides? Can somebody
Yes,
say-
ma'am.
Okay, good. So, yeah. So we started work on cognitive stimulation therapy. The plan was since 2013-14, but it was not materializing. And to 2018, I had the opportunity of collaborating with the person who gave cognitive stimulation therapy, and along with 3 other sites in India, Chennai, Thrissur in Kerala, Dr. Shaji. Chennai was with Sridhar Vatheshwaran, and Mysore with Dr. Murli Krishna. So we were the 4 sites. We decided to test, adapt, and test cognitive stimulation therapy for Indian population. So this is an evidence-based, not just a cognitive intervention, but also a psychosocial intervention. And we'll see why it is called a psychosocial intervention. It is a brief intervention. There are 14 twice weekly sessions over 7 weeks. So twice weekly sessions over 7 weeks, only 14 sessions. No, it is not something very unique. How did they come about CST is they went through a literature review and looked into all the main available non-pharmac treatments for dementia, and whatever appeared to be the most effective through consensus, those interventions were combined to create the CSC program. And several cultural adaptations have happened over the years, including in Japanese. And in India, we have done a North Indian Hindi adaptation, a Kannada adaptation, and a Tamil adaptation. And the sessions aim not just to single-mindedly improve the cognition. The aim of the session is to actively stimulate a person with dementia and to find a reasonable level of engagement with them. So this is very important for the continuity of care, and also for why it is called a psychosocial intervention. Social engagement is very important with people with dementia because most of them are socially isolated, even if they're staying with families. And the aim of CST is also to provide an optimal learning environment and give a person social benefits of a group. Like we do all our, MBBS studies in group study. Similarly, cognitive stimulation in groups has a far better effect size in terms of outcomes as compared to individual cognitive stimulation therapy, which we'll see later. So studies have been conducted all across the globe, including in Europe, Japan, and Asia. And the various cognitive outcomes are comparable to donepezil for mild to moderate dementia. So this is published work, though even I feel these results are a little ambitious because they are not looking at long-term outcomes. They're looking for short-term outcomes, less than 6 months. But having said that, it's a cost-effective intervention, and there are significant improvements, not just in cognitive function, but also in quality of life. And we'll see other soft parameters which have been used to define why CST is a preferred treatment for persons with dementia. So who can deliver it? It's a wonderful treatment because any person who is living with person with dementia, or anyone who is working with dementia, with minimal training, and just follow the CST manual, and we have come with the adaptation, family member, a care worker, even paid, minimally educated attendants, psychologists, obviously, psychiatric social workers. My main intervention was the MPhil psychiatric social work, candidate that I had, she had passed out and she was a research officer, occupational therapist, even nurses. Anybody can deliver. It's so simple. It can be done in any setting, including homes. We have also done virtually during COVID-19 pandemic, long stay facilities, hospitals, or even daycare centers. So what is the evidence base? It improves general cognitive functioning, language, comprehension and production both, and quality of life. Then there have been qualitative studies on the experience of the session as narrated by the clients, their carers and staff. So it includes a very positive aspect of being in a group. They find the environment supportive, non-threatening, and CST participation in CST group therapy has been shown to have people have better mood, better confidence. That is due to social stimulation and social acceptance, and finally feeling socially involved in a cohesive way, and also improved concentration. And concentration is an attentional parameter, so it's a core cognitive parameter. So apart from group CST, which is for 7 weeks, 14 sessions, then the concept came that after 14 sessions, what? Then a maintenance CST was defined as 26 weekly sessions, half a year. The same kind of sessions which are there in the original 14 sessions. And interestingly, with maintenance cognitive stimulation therapy, the continuous benefits were seen only in quality of life and not with cognition. And that is why I would say that though it has been said to be comparable with pharmacological treatment, it is not comparable. The maximum benefits are seen when we combine CST with an anti-dementia medication. So yes, it has a role and probably an adjunct role and not a standalone role. Then what if there is no group? And sometimes it's difficult to bring the patient from home to a group setting. So individual CST was divided. It was delivered on one-on-one basis by family carers. Even in individual CST, they found that cognitive function and quality of life did not improve much. So the social stimulation, which comes from participating in a group of people with similar disorder, plays a key role into the impact of CST, because when the same sessions are done individually, the change in cognitive function is not seen. However, there are other benefits, like persons with dementia have reported an improvement in relationship with their carers. Carers also reported improvement in their own quality of life. Both of carers and clients valued the mental stimulation. They found the activities to be meaningful, and the activities help them keep in touch with the world around them. So what about virtual CST? So virtual CST was developed in response to COVID-19 pandemic. Sorry for the typo. It was developed through stakeholder engagement and international field testing, including a UCL-based RCT. We have done our own RCT. I'll show the results later. It is virtually the same as group CST, the same guidelines, the same key principles, and it followed the Making a Difference manual for CST. And we adapted it in RML from April of 2020 because we are already running a trial. So we couldn't leave the trial. We got ethical permission from Institutional Ethics Committee and started using platforms like WhatsApp, Google Meet, and Zoom with our clients and carers. In terms of cost effectiveness metrics, London School of Economics conducted a cost effectiveness analysis and found to be more cost effective, both the group CST and the maintenance CST. NHS conducted its own economic evaluation vis-a-vis antipsychotics, and they found that there were cost savings and QOL improvements, and they estimated the financial savings to nearly 55 million per year for the NHS. So in 2018, UK NICE guidelines recommended use of CST for persons with mild to moderate dementia to promote cognition, independence, and well-being. This was the only non-pharmacological treatment advised by NICE guidelines. And there was a audit conducted by Memory Services National Accreditation Program, MSNAP of UK, and they found that 96% of PWDs were offered CST by the NHS trusts. And the World Alzheimer's report has also recommended that CST should be offered to persons with early stage dementia. So in all over the world, in 35 countries, now there are CST groups, including India, Japan, Nepal, Nigeria, Philippines, South Korea. So what are the guiding principles? The main idea is that dementia doesn't happen in the day, and neurodegenerative is not a rapid decline. Dementia is not a homogeneous entity. There are various rates of decline seen in person with dementia, and as long as they can engage, we must provide cognitive stimulation. Further, the idea is to, in a playful environment, new ideas, thoughts, and associations can be introduced to help orient the persons both sensitively and implicitly, rather than asking repeatedly date, time, place, person. The CST focuses on opinions to bring about the expression of person with dementia, because they can continue to have their own opinions rather than focusing on factual statements. As we know, person with dementia might be forgetting the facts. It uses reminiscence as an aid. So part of reminiscence therapy is also there. We'll see how. It also involves physical movement, including gross motor skills and fine motor skills. It uses cues and triggers to aid recall. And there is a pattern which ensures continuity and consistency between sessions. So each session does not look a standalone session. It focuses on implicit learning with use of stimulating language and tries to stimulate executive function. So the 14 sessions last for 30 minutes, because we know person with dementia may not be able to concentrate beyond 40 minutes. So there is an introduction for 5 minutes. There is a main activity which is for 20 minutes and a closing activity for 5 minutes. It should be done by a trained therapist, and a caregiver may assist. When we are using the caregiver, we inform the caregiver about the general theme of the session prior in advance, so the caregiver is prepared for the session, especially in virtual and home-based CST. In each session, there's a general theme and a range of activities which follow that theme. The members can group a name to get a sense of belongingness. There is a warm-up activity. There is a reality orientation board containing information about the group. So the group could be freedom group, daily-based group. There is a theme song, and whatever needs are required for the session, that has to be arranged in advance. So the first session is physical games. Then we have a sound session, a childhood session, a food session, a current affairs session, faces and scenes. So that is what visual memory, word association tasks, creativity tasks. Then we have a categorizing session, orientation tasks, money tasks, numerical games, word games, and we end with a team quiz. So I'll share some of the sessions, and we can brush through the rest of them. So at the start of each session, you welcome the client and caregiver individually by name and ask how they would want to be addressed. So typically, our clients did not want to be addressed by name. They wanted to be addressed as Auntie Ji or Dadi, if the therapist was very young, but they didn't want to be addressed by name. So they were asked their favorite song. This was an exercise to break the ice and saying, okay, from now on, this will be a theme song, which will be sung by all the clients and the therapist in each session. Then there was an orientation exercise and a current affairs exercise. And then the participants were asked to draw some memories of their favorite festivals and celebrations. And if it was virtual CST, they had to share on WhatsApp. So these are the pictures that our clients drew. Like this was Deepavali, a boy playing with crackers, a house, and the house being decorated with flowers. Another picture about Deepavali, and now you can see this is somebody with moderate dementia. Now her drawings are so simple and stick-like drawings and parts of the body missing. So she has drawn sweets, she has drawn candle, and she has drawn anar, and she has tried to show that a boy is playing with fuljari. So she is getting all the elements right, but you can see that her artistic expression is limited. So conceptually she is right, but artistically her expression is limited. And this is somebody with nearly moderate to severe dementia. And now you can see her concept is right. She has drawn, an incense stick, and she has drawn a cracker or fuljari. But the drawings are simpler as compared to somebody with mild dementia who has drawn a Rath Yatra and she has colored it. And somebody drew, Rakhi, Raksha Bandhan, and creatively has drawn the hand with the Rakhi. And somebody drew about Savan. Now, Savan is a very important festival in northern India in the monsoon months, especially people from rural background. And she has shown children playing on swings. And it's a little difficult to see unless you see it from tops and sides. And she has drawn a tree and some swings. Then we have the first session. So every day in every session we ask them about some childhood event or some festival, and they draw it. And when we come to session 1, at this stage of their life, person with dementia may not be able to play a lot of games. So we devise some very simple games like playing with a softball. If they don't have a softball, could they catch a balloon or could they catch a cushion? And do a Q&A. Roll a ball towards a circle drawn on the floor or on connected on newspaper. If there is no ball, use a potato. Then we had a race between client and caregiver to remove a cushion cover and then to put it on, just to improve dexterity and make it fun for them. So gross motor skills were concentrated. The next session was for sounds. We had some sound files for indoor and outdoor sounds, including, dog barking, cat meowing, a cow, a bell. A very popular sound was dholak, and people could identify the sound. And then we would show pictures. So there was an auditory and visual association between the sound and the picture. And if there was a correct response, they would be scored as 1 mark. We also use Bollywood songs of 50s, 60s, and 70s, and we asked them if they could identify the song, then give us more information about the song, including singer, movie, did they see the movie, did they have some memory of that song, and very vividly they would give memory of the song. So reminiscence therapy was used very creatively in this session. Then there was a childhood session in which people would give their name, their schools, their father's names, families, colonies, narrate some childhood events. We also asked them if they could show their childhood games, their favorite sweets in childhood. So somebody drew a Ludo. Somebody remembered playing with a doll, so she drew her doll, which is like a rag doll. Somebody remembered this is a game with Northern India, we play gitte. So, and very rightly, there are 5 gitte only or 7. So she is given, though the drawings are very simple, but conceptually she is right. Then somebody playing drawing of cricket. So the 3 wickets are drawn at both ends across a pitch, and both the batsman and the one at the non-striking end have bats. There's a ball in between. So even though there's no bowler. So some aspects are well defined in their drawings. Again, skipping rope, which is very common. Then the next session is food. So yes, there'll be some gustatory tasks, ask people to taste and identify. There is some associative memory tasks, childhood memories associated with food, and also some categorical fluency tasks. Give names of 10 fruits, 5 spices, 5 popular chars, 5 dals, 5 Indian mithai. Then we had another session on current affairs, which is session 5. The clients were given newspapers or magazine and asked them, what have you selected for discussion? They would read if they have not already read. And the client, the caregiver, and therapist, if it's a group, the entire group would discuss the issue for 4 to 5 minutes. Then we also had stimulating discussions on topics for which there's no easy answer, like should men and women have different roles? What do you think of today's fashion? What is your favorite place? And if the client did not respond, we would not force the client to respond, but give them another topic in which they could express their own views. And very non-judgmentally, we accepted all views. The next session was faces. So we would show them pictures of famous people directly or on WhatsApp and identify them, or famous monuments like Qutub Minar, uh, members of their family. Then we would show them two pictures, which one they thought was more attractive, which picture is older, which one looks younger. What do these people have together? So they would say these are Bollywood stars, or these are prime ministers of the country. How are they different? This one is younger, this one is older. So to stimulate not just visually, but also visual association areas. Then we had word association tasks that we always do. So the word associations could be about quantities. If you would say Savaman in North India, it's very common to say Savaman Laddu. Our famous couple in the original UK manual, it is Lauren and Hardy, but Indian, when we had done our pilots, we got these names, Ram Lakhan, Ram Sita. So we started using popular phrases, Hindi idioms, Nachna Hai, so they would respond Angan Teda. And we would give them the first few words of a Bollywood song or a bhajan or a popular song and tell them to finish the song. And then there were creativity tasks about knitting, crochet, collage, then categorizing tasks, a phonemic fluency task, give all names starting with fur, or categorical fluency tasks, give all water bodies, give names of different flowers. And we also did, uh, task, grain sorting task, and the name, place, animal, things, categories game that we used to play as childhood. Give name of a person, place, animal, or thing, beginning with a letter, any letter, and that was repeated for 6 rounds. And the highest scoring person was declared the winner. There was clapping for the winner. So validation, acknowledgement, we tried to bring that in. So again, a psychosocial intervention. So we gave a client a range of things and asked her to group. So she grouped the key with the lock. These are the eatables: a pear, a potato, and a cracked egg biscuit. A spoon with the cup or mug. Then a toothpaste with a soap, and needle with, spool of thread. So this is the way and these are the things which we have used for schizophrenia in my training. So it is, CST is just reinvention of lot of cognitive interventions which were already available and did not create anything new. It just adapted them for persons with dementia. Then these are the grain sorting tasks. Some people found it easier to separate the grain with a partition plate, and some could not do the task at all. And then there were orientation tasks. We asked them to draw a map, draw their residential locality, draw their own house. So this is the map. Somebody wrote that they had 2 rooms, a kitchen and a bathroom and a hall. And this is a nice map that somebody wrote, a 71-year-old female, in which she has even drawn, the buffaloes in the house, a big room and a small room, a kitchen, a bathroom, then bhais ka khol, the shed where the buffaloes are kept. So the visual spatial drawings are, even though very simple, but it shows that the concepts are still right. They knew what was where. They still remember that. And then we had a money game. So Tol Mol Ke Bol, which used to be a TV game. So how we played that. We would ask them, what is the cost of a loaf of bread? What is the cost of ghee? What did it cost when you got married? So women always remembered how much gold costed when they got married. What can you get for 100 rupees? What are property prices now? Then we played some number games like Ludo, chess. We would take out 2 cards and say that what is the next card, higher or lower? Guessing from the number of coins, the total value of the coins. Then we had word games like hangman and a crossword and rhyming tasks. And then there was a general knowledge, and we kept a scorecard. So that was a quiz. So after each session, we summarized the activity. We took feedback. Did they enjoy the session? Did they find it boring? Can we improve the session? We always thank the client and also the caregiver. That's very important to thank the caregiver for attending and contributing. The session would end with the same theme song to maintain continuity. And caregiver would give the number of correct tasks, and we would tell everybody the time and content of the next session so they are prepared, and we would say bye bye, namaste, dua salam. So we did some studies. So this was developing implementation plans for standardized implementation plans across culture that got published. We used the consolidated framework for implementation research. And we took feedback from all healthcare experts, policymakers in Nirman Bhavan, Ministry of Health, person with dementia, not just urban people, but we went to Najafgarh for feedback from rural population. That is how we created our own tasks for different sessions as compared to the tasks for Western population in the CST manual. Then our DM neurology student, for whom I was a co-supervisor, we conducted a single blind randomized control trial using a block randomized design and the same format. And we started assessing not just for cognition on MOCA and ADASCOG, but also for behavioral symptoms in neuropsychiatric inventory, their instrumental activities of daily living and burden. And this is the flow chart. And significant improvement was seen in all. And this paper has got published in Annals of Indian Academy of Neurology in April 2023. So there was change in MOCA score as compared to controls, change in NPI scores, change in ADASCOG, and also change in Zarit burden inventory scores. So in World Alzheimer's Report 2022, virtual cognitive stimulation therapy was one of the first tele-interventions that we did for dementia care during COVID-19 pandemic, apart from virtual supportive therapy, virtual grief, virtual programs for caregivers like STAR, virtual mindfulness, and virtual yoga. So virtual CST was our prime driver for virtual tele-interventions. And these are the papers that have got published about our original work. And I would like to thank Amy Spector, who developed the protocol and who was the international PI. Charlotte Stoner and Emily Fisher were program officers. Dr. Tara from SCARF, Dr. Shaji from Thrisu, Sridhar Vatheshwar again from SCARF, Murli Krishna from Mysore, my research officer Shrishi Dhahuja, who did all the interventions, Tanuja Adhikari, who provided back-end support, Shashank and Yogesh also back-end support, and definitely all patients and caregivers. Thank you so much.
Thank you so much, ma'am. It was really a nice presentation in the sense the person who has actually done it. So it was just a live demo sort of thing that we are having. Thank you so much. Over to chairpersons for their opening remarks. The questions can be invited in the chat box.
Thank you so much, ma'am. It was a wonderful presentation, and especially it was a good learning exercise as all the tasks were explained and how the cognitive stimulation techniques and therapy can be done. And there are 2-3 questions in the chat box which I would like to ask, like from the audience. It is one of the audience has asked, how do you respond if a client gets upset during the session and if they can't remember the facts what we are asking?
Yeah, it's very important that we should be asking facts. We should be asking opinion. Sometimes we ask facts in terms of orientation. And if they cannot remember, let's say their father's name, childhood session. So we say, okay, forget the name. We never call our parents by name. Na? What were you calling your father? So he might say Bauji, Abba, Papa, whatever they were calling, or Babuji, or some were calling their grandparents as their parents, and they were calling their own fathers as Bhai Saab and their own mothers as Bauji and Bhabi. So then that's why the therapist has to be trained to deflect from facts into elements of experience. And experiential knowledge is one of the last to go. autobiographical memory in terms of facts would go, but the experiences won't go. So that is how, and if somebody would get upset, we would just change the topic and help them give a response which we knew that they could give, and then validate the response. Let's see, you remember everything. So you have to continue to validate them, like we validate children, the same way.
And then there's another question, like if there is any evidence of improvement in behavioral and psychological symptoms of dementia with cognitive stimulation therapies.
Yeah, so on neuropsychiatric inventory, Cummings et al., we found improvement not just in symptom severity, but also in caregiver burden associated with that symptom, because the symptom would reduce. So this is our original finding in the Annals of Indian Neurology journal, which came in April. I'll share the paper. It's freely available, but I'll still share the paper on major groups.
Thank you, ma'am. Thank you. Ritesh, sir, any comments from your side?
Majid boss has raised his hands.
Yes, I think we should take his query first.
Dr. Meena, appreciate your presentation, a thought-provoking one. I would like to
Thank
just know whether there has been some comparative studies on mild vis-a-vis moderate vis-a-vis severe dementia as far as cognitive stimulation therapy is concerned.
Sir, our initial plan was to do that kind of analysis, but then COVID-19 struck, and elderly and person with dementia were documented high-risk cases for COVID-19. So we have to shift to virtual, and we could not do so many clients. But definitely we want to keep the project running, and once we have enough data, we'll be doing a sub-analysis for in terms of severity of dementia. But when we have 30 and 30, then the sub-analysis does not make sense.
Okay. Ma'am, there's a question in the chat box. Does it help BPSD also?
Yes,
Yes,
I
that
said neuropsychiatric inventory, we applied NPI, and there was improvement in most of the BPSD, because a lot of BPSD, the behavioral ones, they are also a product of social isolation and feeling non-validated, and perception of apathy from caregiver. One of the first things, because we in India were involving caregivers from day one, and even in the West, when caregivers were involved, the relationship between the patient and the caregivers improved, their social connectivity in their neighborhood improved. So a lot of psychotic symptoms we know get ameliorated once there is social integration within the family. So it's very surprising in a city like Delhi, people stay in the same house and the elderly might be staying all alone with no social contact except for the paid help. But when we started CST, that was the first thing that we were insisting. You talk to them, just listen to them. And when the patient started performing in the sessions, then the family members realized that behind all that not remembering facts, there is a person who is active, who feels, who remembers songs, who remembers tidbits. So sometimes the caregivers gave us very good feedback that we have rediscovered our mother's sense of humor. We have rediscovered that our father remembers so many things from our childhood, because after recent memory loss, they were not even talking about old events. And we know as psychiatrists that old memories last to go. So a reapproachment between family also happened. That is why it is not just a cognitive therapy. There is a good psychosocial component. And even when cognition declines, the behavioral symptoms, they continue to be stable. The social connectedness, that continues. So finally, at this stage of life, those are also important targets.
There are one or two questions that people are asking, where will they get this manual, madam?
Yeah, so
CST manual.
Yeah, we are in the process of compiling and publishing. We have had a very difficult time with COVID-19, so a lot of backlog papers are there. And yes, we'll make it free to use for everybody. I mean, finally, the whole idea of doing this research was that we can have a low cost, sustainable, innovative interventions for person with dementia, which anybody can, implement just following the manual with minimal training. So that
Even
is
at
the
home.
whole idea. Yeah.
Yeah, ma'am, I think you're on the right track because the way you presented it was actually simple and practical, and it should give results. What
Yeah.
it seems.
Yeah.
And ma'am, you are talking about cognitive stimulation versus social isolation. So the way that society is being now positioned. So suppose the old comparison of rural versus urban. People are
Mm.
sitting on a chapal. They are not in their home. They're in a common place and sitting there, and elders are there. So uh, I think this would be protective against cognitive decline.
Yes, definitely. In fact, there are some studies about urbanization and dementia, especially from Australia. So in urbanization, you have more that is about Australia, that you have more air pollution and greater risk for environmental inputs in environmental precipitating factors or contributing factors for mental illness. And their rural is pretty isolated, so they feel that it would be cognitive understimulation. The reverse is true about India. Our rural areas are, they're a hotbed for conversation. They know everything about everybody. Even the current affairs task that we devised for Najafgarh was current affairs in the Najafgarh village and not about the whole country. Their gross motor task for men was how to, plant a tree, plant a shrub. For women was how fast they could milk a cow. Uh, then fine motor tasks included how to roll a laddu. So the rural data I have not presented. We have to customize it for a target or target clientele. So whatever fits, whatever cultural activity fits into our framework, we should devise that. We should not be restricted even by what I'm proposing here for urban population in South or in East or West. If some other activity fits the bill, please use it.
Okay.
Very interesting question. Can you comment upon patients, old ones, who use benzodiazepines for long period of time? So we have patients of chronic benzodiazepine dependence who are unyielding in clinical discussions, get offended easily, usually have difficult personalities overshadowed by memory issues. So, so somebody
So-
having personality issues, benzodiazepine dependence, as well as cognitive impairment. It might be benzodiazepine induced, or it might be anything else. How
Yeah,
do you deal
so
with that patient?
benzodiazepines as part of clinical care, we had tapered off and stabilized the patient before we started CST. So the because we were using adjunct CST, we had no intention of using CST as mainstay of treatment. So patients were pharmacologically stabilized with minimum of psychotropics before we started CST. Yes, one cognitive enhancer. If they had a BPST, then low dose antipsychotic or antidepressants, as the case may be, and strictly no bens, because bens cause their own set of problems. But the point about difficult personalities, we had people with cluster B traits who were disruptive, who were difficult to engage. And with virtual CST, yes, it was better. But sometimes they were hampering the group dynamics. But now we know virtual CST with caregiver works as well as group CST. Then if there's somebody who is disruptive due to his own traits, best to shift him to individual CST or virtual CST.
Okay. And ma'am, how much does being in a group help versus individual?
Please say that again.
How much does the CST being in a group help as versus CST individually?
Yeah, so the studies from the West where people are isolated and staying in care homes being in the group is important because that is the only time when they are in a group setting. But in Indian families, even if the son and daughter-in-law are not talking, they are too busy to talk, the servant is definitely talking. So Indians are not so isolated. So the group CST, yes, it has benefits. Some people made friends even on Zoom, and they continue to chat with each other. But our patients are not so isolated, especially our population. They had people to talk to, even if it is not their own son and daughter-in-law. They were talking to their daughters on the phone. They were talking to their maid servants of neighbors. They knew everything about the entire colony, and they may forget details, but they were not like completely socially, withdrawn or forlorn, apart from their own psychopathology.
And
So, ma'am, cooking is good, you mean to say?
Gossip. That
Yes,
is Alim's favorite pastime. So
yes.
he
So
will not have cognitive
finally,
decline.
finally from IPSS, we know schizophrenia has good outcomes because of our family, and our family and culture and society, they do a lot more than we psychiatrists can do. So we are very fortunate to have traditional structures.
But I think in the coming time, the
One,
scenario would grossly change. It has been, I am seeing that in urban areas, most of the elderly are living alone. Their children, they are living abroad or they are migrating to some other places in India for their job. And ultimately, the older people are left alone for their, and nobody is there to take care of them. Those
So
problems are
we,
really coming.
yeah,
So urban rural differences are likely to come up
yes.
during the therapy also.
Yeah, we faced this issue when COVID-19 started, and a lot of volunteers wanted to help RML. And we said, instead of helping RML, you go back to your resident welfare association in Delhi. There is Bhagidari program, and you identify elderly who are living alone, or couple living alone, or people who need help, and connect us with them. So this is one of the social interventions we did, and we got very good response, because people felt that, where do you find poor people in Delhi unless one goes to slums? But there's something very meaningful which can be done there in their own neighborhoods, in their own societies, by connecting to the elderly. So COVID has been, you know, has helped in building bridges beyond traditional social work. People have become more engaged to their communities, even if some families are, uh, you know, being torn apart, or because of migration, elderly are living alone. It's not ideal, but definitely rural elderly are much better placed than the urban ones.
And ma'am,
Yeah.
there is a question in the group chat box, like what are the guidelines for how many people to be enrolled in one group for the therapy, and how frequently can we repeat the therapy sessions? It should be once in a week, or if
Yeah. So
people
6 to 8, yeah,
and twice a week, or what?
yeah, 6 to 8 people, because then you have 6 to 8 caregivers also. You know? And we do twice weekly, and we also tell the caregivers, this was our adaptation, that whatever we tell in a session, please continue to do at home with the client till the next session. And twice weekly engagement, so for 14 weeks. And then one should go to maintenance CST and start doing the same thing once weekly. The same task, the same types of tasks.
And
So Dr. Majid has raised his hands.
Dr.
Dr.
Meena,
Majid.
ma'am, can I come in?
Yes, yes.
Yes, ma'am. So what Dr. Hitesh Purana, my dear brother, was saying, I fully agree that IPSS, as you were saying, it is almost a 3-4 decade old phenomena now. I think we are in a new India where things are going haywire. We are moving from joint to nuclear families. And I think the IP that was done, I think there is a need to do it again and see how much things have changed over the period of 3-4 decades. I think we will have definitely had a significant change since then.
Yes, sure. We should continue to do research, which is typical for our South Asia, to solve our problems. And we should definitely revisit data so we can know the trends.
One question, I think that is in the chat box also. Does one size fit all? This therapy works with every child, think every type of cognitive decline, whatever supplies work, based on experience, even though you've not done
I
a
couldn't
lot
get
of
the
studies on that.
question.
So what is which?
Is
Yeah,
it like,
There's a question also in the chat box. Yeah. And in that, tell.
is it like,
Bolo.
is it like one size fits all? Can it be used in minimal cognitive impairment and age-related cognitive decline
Frontotemporal dementia,
or
anything.
dementia people like
Or you think there's a
frontotemporal
subgroup
dementia,
which
vascular
works,
dementia?
this works
How?
well.
okay. So the evidence for cognitive stimulation therapy is for all cause dementia and not categorized as per the etiological diagnosis of dementia. Having said that, there are conditions like rapidly degenerative dementias. Obviously, CST is not going to work. It cannot work against biology. But when we think about dementia, we should not be thinking of a downhill diagnosis. It's a heterogeneous condition. Epsilon E4 homozygosity is very different from epsilon 2, 3 heterozygosity. So we have to understand, even in AD, it's heterogeneous. Vascular dementia definitely has a step-ladder pattern, so it can be stabilized. Even if there is neurodegeneration and cognitive decline 1 year down the line, a person from moderate dementia becomes severe dementia, at least in that 1 year, we have added life and quality of life to his experience and to his existence, rather than waiting for him to slowly go downhill and into the sunset. So what we are able to do in present moment is sometimes far more valuable. And uh, in all my years of experience with the elderly, the patients I had no hope for survived and did very well. The patients I felt will stabilize and they had some vascular event or some comorbid cancer being diagnosed and they went downhill rapidly. So as long as we have the patient, we should be optimistic in trying. And this is a low-cost therapy. We can train the family. It's a very enjoyable therapy. This because there's implicit learning. We are not asking them, overtly to do a task or to engage in something which appears burdensome. And our goals are also very simple: social engagement, interfamily bonding, some cognitive stimulation, quality of life, experience of being in a group. I mean, those are also valuable targets at this stage of life. Instead of being diagnosed with dementia and waiting for things to deteriorate and to pass away, and sometimes it can be many years between diagnosis of dementia and the eventual sunset. So in this intervening period, if we can offer something, and we know there's very little pharmacologically we can offer, then why not? That's my point. I'm not saying it is going to do wonders for cognition, but it can make people happy. If it can, why not? QL improves.
Definitely. Ma'am, any comments regarding use of this therapy in negative symptoms of schizophrenia?
So I have never used for negative symptoms of schizophrenia, but cognition being cognition, and we know there are cognitive deficits in schizophrenia, and there is impaired social cognition in schizophrenia. So it is a worthwhile area where we should do original research. It looks very promising, but let us do original research to reach an informed answer. But yes, why not?
Ma'am, there is a question like, while grouping the people into the sessions, do you group them according to their educational profile, personality profile? How to make the groups? Like,
Yes. So when we did our initial pilots on barriers and challenges for CST, the CFIR protocol SR implementation plans. So we asked, would they want gender-based groups? So the urban people said, no, we are fine. The rural people wanted, they didn't engage, the women didn't engage till the men left the room. So you have to look into the sensitivity of the client rather than our own presumptions about the client. If there was someone who is overtly disruptive, yes, we took them into individual CST or VCST if we could not intervene actively. But if they can, get along in a group, and at this stage of life, at least in urban Delhi, people are very cosmopolitan. And in rural Delhi, they still did not want to talk across gender. So gender was a deciding factor for group. But beyond that, education was not a factor. Personality profile was not a factor. Rich, poor were not factors. We have done, an awareness sensitization program for New Friends Colony in Delhi, which was one of our original sites, which is the posh area of Delhi. They were also accepting. And Najafgarh people were accepting. In fact, they became friends. They became WhatsApp friends, Najafgarh people and the New Friends Colony people. So disease is a big, unifier. They found common things.
Yes, yes. Thank you, ma'am.
वाह,
Ma'am,
वाह, वाह. सलीम बोलो
Yeah.
बोलो बोलो कुछ.
so, ma'am, what I could understand is anyone who has a bit of common sense and patience can deliver this therapy.
Yes, yes,
Which you don't have.
exactly.
Yeah. So how labor intensive and how cost intensive it is actually on the ground right now?
Yeah, so our research fellow was paid by the grant. Shrishti is there. Maybe Shrishti, you can put on your video. And the things required, she's there, Shrishti. And the things required for therapy sessions like a potato, a ball, a newspaper, a cushion, all those things were those which are available at home. So they didn't have to buy anything. Even coloring pens and pencils, they had their grandchildren. We wanted to do with instruments and things which were readily available. And it was also COVID. So they didn't have to go and hunt for things. Whatever is available in the house, finally the goal is not the best drawing. Whether they can conceptualize and remember and express themselves through drawings when they cannot express themselves through language. So I don't think so it's costly apart from therapist cost. And therapist cost need not be much because a 30-minute session, 6 clients, 8 clients, a group session. So I don't think so therapist cost would be much if we divide according to the number of clients in a private setup. The major costs that we were analyzing when we were talking to stakeholders were transport costs for the patient and caregiver to come to the setting. So if we can decentralize, if we can train, we had plans to train panchayat people and school teachers to deliver CST, which if everything goes well this year, we would go back to Najafgarh. She has already visited Najafgarh site to explore who else can deliver CST. And if they can deliver on ground, the costs come down. So it's
And
not very expensive.
Absolutely, absolutely, ma'am.
there is another question in the chat box. Are there any online resources available for the family members and caregivers to implement CST at home?
Yeah, so there is a divide between our vision and the international vision. The international CST is patented. They have manuals which need to be bought. Our way of thinking, the Indian partners, is that we want low cost, innovative, sustainable, free resource for everybody. So that is why there is a Gatirod, if that is a good word. There is an impasse between us and the international partners because we want to make our work at least publicly available for free to everybody. And they want to stay in the era of patents and restricted access and those kind of things. But I think that would be solved. Otherwise, we would have published by now. We already have everything, but they feel very territorial about their intervention when it is just a compilation of earlier interventions. It is not something new. A lot of these tasks, grain sorting and all, we were all doing for schizophrenia patients and categorizing tasks and all that. So that is where it stands. Yes, inputs I can give, but a proper manual, it would take us some time to publish it. We'll publish it as part of our paper publication, and then
Today's
it will
record,
be free.
today's recording is good enough for a person who is slightly inclined and
Yes,
slightly
yes.
in this regard.
Additionally,
Yes, yes,
Today's recording and they can carry on.
yes. We are giving a framework for family also. If family is also minimally educated, and they ask, like people ask us about sleep hygiene, and we are too busy to tell them. We say there are sleep hygiene resources on the net. Please read and implement. And this is the kind of CST therapy we want to create. So there are 14 sessions. There is a resource. In each session, there is a menu of activities that you can do, pick up any and do. That is the whole idea.
So ma'am, we'll share the
Whatever
with everyone.
additionally, but international resources are available. We need to Indianize those first before using it in our country. Because every activity which they are doing won't be suitable in our culture.
Yes, so apart from the themes of the session, we created all activities as per our population. So there is a Tamil version which looks into the Tamil culture, and the Sridhar Vatheshwar has created that. And in North, we think of South as homogeneous. It is not. Its culture very different. There's also Kannada manual, which Murli Krishna and his team have devised, which is slightly different. And we in Delhi, we have created two manuals, separate ones for urban and rural, because our urban and rural are culturally very different as compared to Chennai urban and rural, who were culturally nearly similar. So apart from the themes, all tasks are something that we have created. So if there's a word association task, all the incomplete sentences are ours. We have created them. All the games were something that we knew, and we have taken inputs from patients, from NGOs, from psychiatrists, from neurologists, from policymakers, from artsy, urban, rural, retired people. So we have taken a lot of inputs before we said that these are the acceptable options for different sessions.
Thank you. Amrit, I think we have covered the chat box. Aninda,
Yes,
we have
yes. I think she has answered a lot of questions.
Yeah,
The
and
last 30 minutes, we have been relentless on her. And she's been smiling and answering.
No, I think let me state it is
Tufan sir wants to say, I think, something. Sir, you want to answer?
the most optimistic presentations of dementia that we had. So we are very, very positive.
Alim is very happy.
Yeah. So I'm an optimistic person. So my therapy and my perspective and my treatment, it flows from that. And with God's grace, God does all the work and we get all the credit. So big beneficiary of that. And Dr. Abdul Majid has written about collaboration. Yes, I'm very open to collaboration, because finally India is diverse. We need to adapt it for different settings. Delhi is not the same as Lucknow, is not the same as Bhubaneswar, and urban and rural are different. Tribal population is another population which are completely neglected for dementia care services. So I think if we can all collaborate, apply for a grant together, and deliver something for India. And there's nothing sacred about 14 sessions. As we develop further, we can develop our own protocols also.
So a whole session might cost somebody 15 to 16,000 rupees or 30,000 rupees. What should be the general cost? If Alim has to do it, he knows it, and he has kept somebody who will do it. What should be the charge, and how much, a 30-minute session? Because cost is the most important thing in private practice.
Yes. So what does a 30-minute session cost? Divided by, let's say, whatever the amount, divided by 6, because there'll be at least 6 participants. Okay, so yes, that makes it affordable. So instead of charging all participants, one can do some charity for elderly, and because it's 30 minutes of your time. So 30 minutes per session. If a session is 1 hour for billing, so it is half of the usual billing. It's only 30 minutes and divided by 6. So that makes it very affordable.
Sure, ma'am. Ma'am, you can put your email on the chat box. Some people were asking for it.
Yeah,
and Tufan sir, over to you.
The chairpersons, they can add. Otherwise, let me complete my comments. So yes, Dr. Khurana, please.
I am really thankful to Dr. Alim, Sir, Dr. Tufan Pati, and Dr. Patoto Joshi for inviting me on this particular talk I am really feeling blessed that the experts have been called for speaking, and they have, madam has made the things which are apparently very difficult, but she has made the things so simple that everybody is thinking that, oh, with some kinds of hints and some kinds of inputs for her, from her, everybody can do, even the family members can also be trained to do these kinds of therapy. I think this is a very clear advantage of calling experts as speakers on any kind of expert forum. And I am really thankful to you, ma'am, and I am really thankful to the Third Day Music Forum for inviting me to chair this particular session, and especially on the auspicious day of Elderly Abuse Prevention Day, and when ma'am herself, when the experts are speaking on this particular session. I'm really feeling enlightened and blessed. Thank you very much.
Thank you. Thank you.
Aninda, can you speak something?
Thank you, sir. I am thankful to the Thursday Musings team, Dr. Aleem sir, Aprit sir, and you for giving me the opportunity to chair the session. And it was a very lucid presentation and was a very good learning experience for me also. And what I feel like cognitive stimulation, it is like it can be used as a brain gym. We call people to do physical exercise throughout the life. So when there is a cognitive decline or age-related cognitive decline, this cognitive stimulation therapy exercises can be incorporated as a brain gym to maintain the cognitive reserve, not only in dementia patients, but I feel. Thank you.
Thank you, Dr. Meena Chandra, for your nice presentation. Simple, suave, inspiring. And I quite appreciate it because of the basic reason that it can be administered by anyone. When we stand at this point, to be exact, drugs have a little scope. They promise very little. And these technologies can be administered by the family members, even by the NGOs who work in remote areas. So it is not going to do any harm. It is going to increase the empathy, to some extent the quality of life, and biologically, it may increase the cognitive reserve. And we have got the flexibility to design our own ways. Not that strictly these questions are to be asked, not necessarily these 14 sessions have to be heard. One has to tell the people who work for dementia, people who work in this fleet, including the family members, this is the guideline. You have your plan, discuss with us, try to implement. We are there to help. And it is really promising. I'm very thankful for you for your simple presentation of this thing, which promises benefit, some benefit at all, if not all benefit. It's not the panacea, but is a great hope. Thank you very much. This is my take on this. No questions.
Amrit, over to you.
Thank you, Meena madam. Just such
Thank you.
simple, something which we always thought must be some rocket science. You made it so simple with simple diagrams, simple songs. You know, for somebody like me who does not know how to sing, or somebody who does not know how to draw, I thought, what will happen once I have dementia? But the things were very, very simplified. You know, and it was lovely. Thank you, Hitesh sir. Even so humble, so cool, and you had a nice way to going about things. Thank you, Aninda. Thank you. I think from today, me and Alim will start doing our brain gyms. Alim does a lot of the physical gym. I think it's time for Alim to have a little bit of brain gym also. Thank you, Tufan sir. Thank you. We had a lot of people who had logged in. You know, we never thought that so many people will be logging in. We had more than 250 logins at a peak of 194. That's really wonderful. You know, day in, day out, every week, that consistency means that people trust the people who come here on our platform, and that's wonderful. So thank you, everybody. Thank you, Torrent, for supporting us. Thank you, IPS Odisha State Branch. We'll have another nice session next week, and we had a lot of questions actually. Today, a lot of questions were asked. So that was also great about it. So good night, everybody. Have a lovely weekend. Meet you again next time. Thank you.
Thank you. Thank you, Amrit.
Bye bye. Take care.
Good night, everybody.
Night.
Bye. Thank you, ma'am. Thank you.
Quite repressing musings today.
Thank you so
Yes.
much. Thank you.
Thank you, ma'am. Closing the meeting.
Bye.